Hi everyone, welcome to the forum of urology. Thanks for joining me here. Today I'll be covering the surgical anatomy of kidney followed by the basic nephron anatomy and relevant physiology points. So starting ahead with the surgical anatomy of kidney. The kidneys are paired organs lying retroperitoneally on the posterior abdominal wall. Each kidney has a characteristic shape and size with a superior and inferior pole, a convex border placed laterally, and a concave medial border. The medial border has a marked depression, the hilum containing the renal vessels and renal pelvis, as we all know. Now, in adults, the left kidney is larger than the right, and this agrees with the morphometric findings in the fetal kidneys. In fact, the right kidney has a mean length of 10.97 cm and 3.21 cm mean thickness at the hilum in comparison to 11.21 cm and 3.37 cm respectively for the left kidney. Also, the superior pole has a greater width 6.48 centimeter mean than the inferior pole at a mean of 5.39 centimeter. Also, there is a statistically significant correlation between kidney length and an individual's stature. So, as it has been my habit, I will reiterate just the take home points or the figures which are difficult to memorize. The right kidney length 10.97 centimeter compared to 11.21 on the left, 3.21 thickness on the right compared to 3.37 thickness of hilum on the left, then 6.48 I'm sorry on superior pole and 5.39 centimeter inferior pole. Moving on, because the kidneys lie on the posterior abdominal wall and against the psoas major muscles, hence their longitudinal axis parallels the oblique course of the psoas muscle. Moreover, since the psoas major muscle has a cone shape, the kidneys also are dorsally inclined on the longitudinal axis. Therefore, the superior poles are more medial and more posterior than the inferior poles. Also, because the hilar region is rotated anteriorly on the psoas muscle, the lateral borders of both kidneys are posteriorly positioned. This means the kidneys are angled 30 degrees to 15 degrees behind the coronal plane or the frontal plane. And moving on, the kidney surface is enclosed in a continuous covering of fibrous tissue, the renal capsule. Each kidney within its capsule is surrounded by a mass of adipose tissue lying between the peritoneum and posterior abdominal wall. This perirenal fat is enclosed by the renal fascia, the so-called fibrous renal fascia of Gerotal. The renal fascia is enclosed anteriorly and posteriorly by another layer of adipose tissue, the pararenal fat, which varies in thickness. So the renal fascia is made up of a posterior layer, a well-defined and strong structure, and an anterior layer, a relatively more delicate structure which tends to adhere to the peritoneum. The anterior and posterior layers of the renal fascia subdivide the retroperitoneal space into three potential compartments: the posterior pararenal space, which contains only fat; the intermediate perirenal space, which contains the suprarenal glands, kidneys, proximal ureters, together with the perirenal fat; and the anterior pararenal space, which, unlike the posterior and intermediate spaces, extends across the midline from one side of the abdomen to the other. This latter space contains the ascending and descending colon, the duodenum, and the pancreas. Inferiorly, the layers of the renal fascia end weakly fused around the ureter. Superiorly, the two layers of the renal fascia fuse above the suprarenal gland and end fused with the infradiaphragmatic fascia. An additional fascial layer separates the suprarenal gland from the kidney, and laterally the two layers of the renal fascia fuse behind the ascending and descending colons. Medially, the posterior facial layer is fused with the fascia of the spinal muscles, and the anterior facial layer merges into the connective tissue of the great vessels. So these anatomical descriptions of the renal fascia show that the right and left perirenal spaces are potentially separated. Therefore, it is exceptional that a complication of an endourological procedure like a hematoma, urinoma, or a perineal abscess involves the contralateral perineal space. With that note, we have covered the basic anatomy, and we would be now focusing on the basic nephron anatomy. So, the medial side of each kidney contains an indentation through which passes the renal artery and vein, nerves, and pelvis. If a kidney were cut in half, two regions would be evident: an outer region called the cortex and an inner region called the medulla. The cortex and medulla are composed of nephrons, blood vessels, and lymphatics and nerves. The medulla in the human kidney is divided into conical masses called renal pyramids. The base of each pyramid originates at the corticomedullary border, and the apex terminates in a papilla which lies within a minor calyx. Minor calyces collect urine from each papilla. The numerous minor calyces then expand into two or three open-ended pouches, which are the major calyces. The major calyces in turn feed into the pelvis. The pelvis represents the upper expanded region of the ureter, which carries urine from the pelvis to the urinary bladder. The walls of the calyces, pelvis, and ureters contain smooth muscle that contracts to propel the urine towards the urinary bladder. The blood flow to the two kidneys is equal to about 25% of the cardiac output in resting individuals. However, the kidneys constitute less than 0.5% of the total body weight. As illustrated in these figures, the renal artery branches progressively to form the interlobar artery, the arcuate artery, the interlobular artery, and the efferent arteriole, which leads into the glomerular arteries. The glomerular arteries come together to form the efferent arteriole, which leads into a second capillary network, the peritubular capillaries, which supply blood to the nephron. The vessels of the venous system run parallel to the arterial vessels and progressively form the interlobular vein, arcuate vein, interlobar vein, and renal vein, which courses besides the ureter. Focusing on the topic of today, that is the ultrastructure of the nephron. The functional unit of the kidneys is the nephron. Each human kidney contains approximately 1.2 million nephrons, which are hollow tubes composed of a single cell layer. The nephron consists of a renal corpuscle, proximal convoluted tubule, loop of Fennel, distal tubule, and a renal collecting duct system. The renal corpuscle consists of glomerular capillaries and Bowman's capsule. The proximal tubule initially forms several coils followed by a straight piece that descends towards the medulla. The next segment is the loop of Fennel, which is composed of the straight part of the proximal tubule, the descending thin limb, the ascending thin limb, and thick ascending limb. Near the end of thick ascending limb, the nephron passes between the afferent and efferent arterioles of the same nephron. This short segment of the thick ascending limb that touches the glomerulus is called the macula densa. The distal tubule begins a short distance beyond the macula densa and extends to the point in the cortex where the two or more nephrons join to form a cortical collecting duct. The cortical collecting duct enters the medulla and becomes the outer medullary collecting duct and then the inner medullary collecting duct. Each nephron segment is made up of cells that are uniquely suited to perform specific transport functions. Proximal tubule cells have an extensively amplified apical membrane called the brush border, which is present only in the proximal tubule of the nephron. The basolateral membrane, the blood side of the cell, is highly invaginated. These invaginations contain many mitochondria. In contrast, the descending and ascending thin limbs of Henel's loop have poorly developed apical and basolateral surfaces and few mitochondria. The cells of the thick ascending limb and distal tubule have abundant mitochondria and extensive infoldings of the basolateral membrane. The collecting duct is composed of two cell types, principal cells and intercalated cells. Principal cells have a moderately invaginated basolateral membrane and contain few mitochondria. Principal cells play an important role in sodium chloride reabsorption and potassium secretion. Intercalated cells, which play an important role in regulating acid-base balance, have a high density of mitochondria. One population of intercalated cells secretes uh, proton, and a second population of intercalated cells secretes bicarbonate. The final segment of the nephron, the inner medullary collecting duct, is composed of inner medullary collecting duct cells. Cells of the inner medullary collecting duct have poorly developed apical and basolateral surfaces and few mitochondria. Except for intercalated cells, all cells in the nephron have in the apical plasma membrane a single non-motile primary cilium that protrudes into the tubule fluid. Primary cilia are mechanosensors which sense the changes in the flow rate of tubule fluid, and not just that, they are also chemosensors. They sense or respond to compounds in the surrounding fluid, and they initiate calcium dependent signaling pathways, including those that control kidney cell function, proliferation, and differentiation and apoptosis. So, nephrons may be subdivided into superficial and juxtamedullary types. The glomerulus of each superficial nephron is located in the outer region of the cortex. Its loop of Henle is short, and its efferent arteriole branches into peritubular capillaries that surround the nephron segments of its own and adjacent nephrons. This capillary network conveys uh, oxygen and important nutrients to the nephron segments in the cortex, delivers substances to the nephron for secretion, and serves as a pathway for the return of reabsorbed water and solutes to the circulatory system. A few species, including humans, who also possess very short superficial nephrons whose Henel's loops never enter the medulla. The glomerulus of each juxtamedullary nephron is located in the region of the cortex adjacent to the medulla. In comparison to the superficial nephrons, the juxtamedullary nephrons differ anatomically in two important ways. The loop of Henle is longer and extends deeper into the medulla, and the efferent arteriole forms not only a network of peritubular capillaries but also a series of vascular loops called the vasa recta. As shown in figure to demonstrate here, the vasa recta descend into the medulla where they form capillary networks that surround the collecting ducts and ascending limbs of the loop of Henle. The blood returns to the cortex in the ascending vasa recta. Although less than 0.7% of the blood enters the vasa recta, these vessels subserve important functions in the renal medulla, including conveying oxygen and important nutrients to nephron segments and delivering substances to the nephron for secretion, and serving as pathway for the return of reabsorbed water and solutes to the circulatory system, and concentrating and diluting the urine. So that's enough for today. We will be continuing our discussion on nephron anatomy in the next session. Thank you.